Please allow me to introduce our next presenter today, Dr. Melissa Forton. Dr. Forton is an integral member of our team here at the Kentucky Infection Prevention Training Center. With a diverse background and passion for healthcare education and research, she plays a crucial role in advancing the Kentucky Infection Prevention Training Center's mission and vision. Dr. Forton serves as a sub-investigator in research and leads in educational development here at the Kentucky Infection Prevention Training Center. Her involvement spans all stages of the process, from needs assessment and training requests to content development and eventual publication online. With nearly 2 decades of pediatric experience at Cincinnati Children's Hospital, Dr. Forton brings a wealth of practical knowledge to her role. Dr. Forton's academic journey includes earning degrees from Northern Kentucky University and Mount St. Joseph University. Her commitment to advancing her field led her to obtain her Doctor of Nursing practice from Valparaiso University in 2018. Since joining KYIP, she has been actively engaged in sharing her expertise through various platforms. She has presented at infection prevention boot camps, grand rounds, nursing conferences, and vaccine workshops, demonstrating her dedication to education and empowering healthcare professionals. At this time, I'll stop sharing my screen and welcome Dr. Forton as we embark on this journey to understand the nurse's role in antimicrobial stewardship, a topic overlooked in care. We can see your screen.
You can see me and you can hear me now, right?
That is correct.
Perfect. Thanks so much for the introductions. Again, I'm Melissa Forton, and I'm going to talk today about stewardship and nursing and kind of where we fit in. A lot of antimicrobial stewardship and diagnostic stewardship is focused on prescribers. And it's a little confusing sometimes where the nurses fit in. Funding for my presentation was provided by the Kentucky Department for Public Health. There was no commercial support, and I have nothing to disclose. The objectives for today include describing the risks associated with antimicrobial abuse, reviewing antimicrobial and diagnostic stewardship programs, and then outline the role of the nurse within these programs. So I want to start out with just a quick review of antibiotics. So we're all familiar with them. Antibiotics can either suppress the growth and reproduction or can kill the bacteria, which would be bacteriostatic or bactericidal. There are many antibacterial classes. We're probably familiar with a lot of these already. And then there's several spectrums of action. Our broad spectrum antibiotics they kill or inhibit the growth of a certain type of bacteria. So they might be a gram negative. So they'll kill a lot of gram negative bacteria. Whereas narrow spectrum is effective against a specific group. So it may kill a specific type of gram negative bacteria. Now, unfortunately, we are often seeing these prescribed for viral infections, and they're not effective. I did want to note that some antibiotics are used to treat infections with parasites, but they're mostly for bacterial infections. And then, of course, antivirals are working against viruses. Their viruses are super tiny, and they attach themselves to healthy cells, and then they can make copies. And the antivirals work by either preventing the virus from attaching to a healthy cell or by preventing it from making the copies. And these antiviral medications are really tough to produce. While we have a large amount of antibiotics that we can choose from, there just aren't as many antiviral medications. Some of the diseases or infections that can be treated with antivirals include HIV. For people that have HIV, the antiviral medication can help keep that viral load low. So it can't cure the HIV, but it can keep the viral load low so they don't become susceptible to other infections. Other antiviral medications can treat COVID-19, the flu, some herpes viruses, and hepatitis. The antiparasitics, of course, are used to treat parasite infections by either killing the parasites or the eggs or stopping the parasite from growing. They can also paralyze the parasite so that it's not dead, but it can't attach to anything. And these can treat things like hookworm, roundworm, malaria, and some intestinal infections like Giardia or Cryptosporidium. And then finally, antifungals, which treat fungal infections by either preventing the fungus from growing, destroying the fungus cell, or destroying the cell wall of the fungus. And these can treat thrush, yeast infections, athlete's foot jock itch, several fungal infections. And all of these antimicrobials that I've covered can come in a variety of forms: powders, ointments, lotions. They can be taken by mouth or through a G-tube, and some are only available in IV form. So I think we can agree antimicrobials are wonderful, whether they're used to treat bacteria or viruses or other ailments, and they've just saved millions of lives. There's no argument about that. However, they're not benign. My generation grew up, we always had antibiotics to look for, to take advantage of anytime we were sick or we needed something. But we don't always think about the fact that they can harm people. They do have side effects and they can cause harm. So any antimicrobial has the potential to cause side effects or allergic reactions, including anaphylaxis, which is a life-threatening reaction. And you can get these side effects even if you've taken the same medication in the past. The most common side effects are going to be with the GI system, with diarrhea, nausea, bloating, but you can have other side effects, including yeast infections, dizziness, rash, photosensitivity, low platelet counts, hearing loss. So let's talk about a class of antibiotics called fluoroquinolones. So this is an example. Again, fluoroquinolones include medications like ciprofloxacin, levofloxacin, moxifloxacin, and they're fantastic medications that treat a variety of different types of infections. However, these can have some significant side effects, including tendinopathy or tendon rupture. Now, the people that develop tendinopathy, about 10% of those will suffer from long-term pain and decreased range of motion. Often when we think about side effects, when a person has a side effect, if they can stop taking the medication, those side effects go away. That isn't always the case. Fluoroquinolones are associated with an increased risk for C. difficile infection. Now, it's less common, but people can have neurological symptoms like confusion, hallucination, seizures, and nerve pain. And because of the risks associated with fluoroquinolones, the FDA has stated that fluoroquinolones should only be used if there are no other options. One of the potential side effects that we have from using antibiotics are C. difficile infections. And that occurs when there's a C. diff spore in the intestine that's able to germinate and produce a toxin and cause infection. Now, we all have, or not all of us, probably 20% of us have a C. diff colonization, meaning that we have a type of C. diff in our intestines, but it doesn't cause an infection. It doesn't release a toxin. However, if you do have this toxin producing C. diff spore and it's able to germinate, then you're going to have some trouble. What happens, we have, our healthy mix of bacteria and other microbes in our intestines. And anytime we get kind of those healthy balance out of balance, then those infectious or pathogenic bacteria can then reproduce and take over and cause symptoms. People that get a C. diff infection can have diarrhea sometimes up to 40 times a day. They might have fever, belly pain, lab changes, values changing, and then people can get severe infections where they become septic and require ICU care or even surgery. And just to tell you how significant and dangerous a C. diff infection is, 1 out of 6 people who get a C. diff infection will get it again within 8 weeks, even if they receive proper treatment. 1 out of 11 people over the age of 65 will die within 1 month of diagnosis. And the C. diff infections are considered an urgent health threat by the CDC. There are also some really serious skin reactions that you can get. This not only from taking antibiotics, but other medications. These are Stevens-Johnson syndrome or toxic epidermal necrolysis. And these reactions cause really widespread skin pain and rashes that end up blistering and cause the skin to shut off. These are exquisitely painful. They can affect the eyes and mucous membranes. And sometimes, depending on the amount of skin involved, these patients have to be transferred to a burn center for treatment. Now, luckily, this is very rare, but it is something that can happen. Another thing that we have to think about is antimicrobial resistance. And we heard a little bit about this already today from Dr. Chad Eldridge. This, again, urgent global health threat. And you can see from this slide from the CDC, some of these, like CRA, increased 78% between 2019 and 2020. So some of these, as you can see, just have just exploded, and we really need to get a handle on it. And again, you heard a little bit about this from Dr. Eldridge earlier today, but again, our bodies are filled with this mix of germ. Some of them may be resistant. Some of them may have the ability to make us sick. When we take an antibiotic, a lot of those good, healthy germs die. In addition to whatever germs are causing our infection, we're going to unfortunately kill off some of those healthy germs. When that happens, we are left behind. What's left behind is a bigger quantity of those antibiotic-resistant bacteria, which are then able to grow, and that, of course, can then, cause an antibiotic-resistant bacteria infection. And I like this image. This is an image from a pediatric infectious disease specialist in Cincinnati who looked at the effect of antibiotic on the gut biome of a pediatric patient. You can see that on the left circle, this was the stool from the patient before any treatment. And you can see that there's lots of different types of microbes. The circles represent the quantities of those different types of microbes. And then the second circle shows us December 12th, which was 6 days later after the patient began an antibiotic. You can see how much that biome has changed. Easily, E. coli is now the most, the largest quantity of microbes, and all of those other microbes have diminished in size. By December 20th, this has gotten even worse. There's even more E. coli, and those other bacteria and other microbes have again diminished in size. And unfortunately, this E. coli this little patient had was drug resistant, and the patient did eventually develop an invasive resistant E. coli infection. But I think this is just a really powerful way to show how quickly and how drastically the biome can change in reaction to an antibiotic. And so in the perfect world, people with infections are going to get an antibiotic, they're going to get better. But unfortunately, we're in a world where we have a lot of antimicrobial resistance. So we often have to prescribe second or third line antimicrobials. And oftentimes these second and third line medications don't work quite as well. And then patients have an increased risk of developing side effects or reactions. They also will increase costs, increase the length of hospital stays. Patients may take longer to recover, and then there's increased mortality. Some patients, and these are including patients I care for, have had to remain inpatient for IV antimicrobials because there were no oral medications available for their resistant infection. And I don't think it's a secret that we overprescribe antibiotics. And we often think that if we personally take responsibility and we don't abuse antibiotics and we rarely take them, that we're at a low risk of acquiring an antimicrobial resistance infection. And unfortunately, that's not true. There is a correlation between antibiotic prescribing and antimicrobial resistance, even at county and country levels. Countries that have a high rate of antibiotic use also have a high rate of resistance and vice versa. So, even if you are a patient or a person who just rarely uses antimicrobials, but you have an infection, you take a medication, an antibiotic for that infection, even with that one-time course of antibiotics, you still have increased odds of developing a resistant urinary tract infection at 2 months and 12 months following that course of antibiotics. So even if you don't abuse them, you take them appropriately, rarely use them, you are still going to be susceptible to antibiotic-resistant infection if there's overuse in your community. Studies have shown that a good deal of antibiotic prescriptions are either unnecessary or inappropriate. About 30% in outpatient and acute care hospitals and up to 70% in long-term care settings. And inappropriate use can include getting antibiotics for a viral infection, the incorrect dose. The patient has symptoms that really don't warrant antibiotics, or the physician just choosing the wrong antibiotic for the type of infection that they have. I read a study just yesterday about a Northwestern and Children's Hospital in Boston did a study where they looked at over a 5-year period, looked at antibiotic prescribing and looked at the diagnosis associated with that prescription. And they found that about 25% of the time, the patient's diagnosis did not warrant an antibiotic, and yet it was prescribed. So now that we've talked about the problems with overprescribing, antibiotic resistance, the side effects, inappropriate use, how do we fix it? And that's where the stewardship programs come in. Stewardship programs seek to use healthcare resources wisely by reducing unnecessary testing and treatment, reducing costs, reducing resistance, and improving patient outcomes. We first heard about antimicrobial stewardship in the late 90s. But it wasn't until 2007 that the CDC, SHEA, and IDSA set out guidelines for antimicrobial stewardship programs. And you'll often, even with me, will hear antimicrobial stewardship or antibacterial stewardship. I think we have really often called it antibacterial stewardship, but really it's not just antibiotics that we're worried about. It's also antifungals and those antivirals as well. So you'll hear that term used interchangeably. So one of the primary reasons that stewardship programs were developed was to decrease antimicrobial resistance. And so, of course, we do that by decreasing the unnecessary use, try to diminish or decrease the use of broad spectrum antibiotics, and ensuring that the course lengths are appropriate. There are many studies that show that shorter courses of antimicrobials work just as well as those long courses. They're less costly and they have less risk of developing side effects for the patient. So again, decreasing things like C. diff and those skin reactions. Now, stewardship teams usually include physicians, pharmacists, lab personnel, and some of the interventions that they use is education, cascade reporting, and monitoring culture results. Diagnostic stewardship is a large part of antimicrobial stewardship, but only was described in the literature in 2017. And diagnostic stewardship is referring to the process of ordering, performing, and reporting test results to improve diagnostic accuracy, optimize treatment, and improve patient outcomes. So when a clinician orders a test, he or she needs to think about the pre-test probability, which is something that physicians learn in their training, but it's really about the likelihood the patient has the infection that I'm testing for. So an example would be if someone comes to an emergency room in Kansas in the middle of the winter and they have fever and body aches, it's probably more likely they have the flu than if they have something like malaria. So we probably wouldn't test for malaria. There wouldn't be a good reason to test for it. The probability of them having that is really low. Doesn't mean you should never test for it, but in most cases, that's just not something that you're going to see in Kansas in the middle of the winter. So clinicians have to think about what tests to order, what's it going to measure, and what is it going to provide? Is it going to change the way I treat the patient? And we found that a lot of times tests don't have a real high value. They have a low value, and they don't really change the way we treat the patient or the course of the treatment. Now, one problem is that within the order sets and things like Epic or electronic health, medical sets, the tests are included as part of an order set. So if you think the patient has pneumonia, for example, you can click that button and it will order all the tests and medications and things like that for the patient. And it can include tests. So the physician has to take an extra step to go in and remove the click or cancel parts of the order. So sometimes they just get ordered without us thinking much about them. So remember, antimicrobial stewardship wants to reduce antibiotic resistance, reduce unnecessary antibiotic prescriptions, reduce costs, reduce the length of stay, and improve patient outcomes. While diagnostic stewardship wants to improve the use of testing, reduce diagnostic errors, reduce unnecessary testing and treatment, improve patient outcomes, and reduce healthcare costs. And I like this graphic because it kind of shows how much stewardship plays a role or should play a role in the patient treatment. So the blue line indicates the path of the patient, from the patient being evaluated to the final diagnosis and treatment. And you can see that early on, diagnostic stewardship begins to play a role. And that's, again, when the clinician is asking about symptoms, deciding if the patient needs a test, and then ordering that test. Once you get those tests ordered, antimicrobial stewardship really kind of joins the party and they're both present now for the rest of the patient's visit. Antimicrobial stewardship can help us with guiding, guidance for prescribing, reviewing any test results, at which point we may have to make adjustments to our original treatment. Stewardship is still in there, again, talking about antibiotic susceptibility reporting. And then all of this, if it works together perfectly, we're going to have an appropriate diagnosis, we're going to have an appropriate microbial regimen, and we're going to have the appropriate length of treatment. So as I mentioned earlier, the stewardship teams usually have infectious disease physicians, pharmacists, and lab personnel. These teams have always been intended to be multidisciplinary, and sometimes in the wording it does mention nurses, but nurses usually aren't a part of the team. Sometimes infection preventionists will be part of the team, and often the IP is a nurse. So maybe that's where they feel like the nurse is included by having an IP involved. But nurses are a really vital and important part of any healthcare team. And that includes stewardship. We're the largest healthcare profession with over 5 million nurses and just under 1 million LPNs in the US. We provide most of the care to the patient. We spend the most time with them. JCO updated their antimicrobial stewardship standards and specifically included nurses in the multidisciplinary team in 2022. And so when I talk about nurses in this presentation, I'm talking about both nurses and LPNs. Because we spend the most time with the patients, doctors rely on us and seek or should seek our input. We have to rely on us, and we are able to influence their actions. Now, I've spent most of my career in a hospital environment, so I've always had doctors available to come see a patient. But if you work in a facility where there isn't a doctor or APP on site, they really have to rely on you for all the information that they get to help them make the decision on what to do next. And that includes, making sure our documentation is accurate as well. Well, nurses are already involved in a lot of the aspects of stewardship. We're monitoring the patient for signs of infection and any response to antimicrobial therapy. We practice infection prevention and control measures by doing things like putting patients in the appropriate isolation or wearing the appropriate PPE, which we've talked about today. We do a lot of the education with the family and the patient. We administer the medications. We document all of these things that we've done, and we are on the lookout for any side effects or any patient who's seemingly healthy but suddenly has symptoms of an infection. We're also the prime communicators with the lab, with the medical team, patients and families. And we also play a role in antibiotic de-escalation, like discussing whether the patients can be transitioned to oral medications. One of the most important stewardship roles that nurses perform is accurate allergy documentation. About 95% of people who report an allergy to penicillin don't actually have a penicillin allergy. So when you report a penicillin allergy, but you need a penicillin, you can't take it, then you're forced again to take those second and third line antibiotics, which again can lead to an increased risk of antibiotic failure. You do have an increased risk of developing surgical site infections, increased length of stay in the hospital. And why do people report this allergy if they don't have it? So I think probably you've heard this often, as nurses, They have a close family member who has an allergy, so they've never taken it. Or they may have said, oh, when I was a kid, I took penicillin and my mom said I got a rash, so I've never taken it since then. So it's important when someone tells us they have an allergy to penicillin or any other medication that we ask a lot more questions. We have to ask, the good follow-up questions and document all of the answers. So we'd ask, what was the reaction that you had? How soon after taking the antibiotic did it occur? Did it occur right away? Did it occur halfway through? Did it occur at the end of the antibiotic course? And if they do say they had a rash, we need to find out what kind of rash was it. Was it hives? Was it a bumpy sandpapery rash? Was it red? Did it start right away? And then other questions like, what age were you when this happened? Or how long ago did this happen? And then what kind of medications have they taken since then? So some patients might say, I'm allergic to penicillin, but I can take amoxicillin or something like that. So it's, again, important to document that. When patients are describing a rash that they had when taking a medication, it's important to kind of figure out, do they have hives, which typically occur pretty soon, like within 6 hours of beginning the medication. They're usually itchy, kind of splotchy. Sometimes they're really big. A lot of times they're reddish, but if you have a darker skin tone, you might not be able to see that erythema. Whereas a maculopapular rash is what we're going to see most commonly. And that's going to occur usually 3 days or more after the antibiotic was started. And usually if you have a maculopapular rash like this with taking a medication, it's still safe to take it in the future. You usually are not going to have this skin reaction again. So it's something like the physician will have to figure out, but it doesn't mean they can't take the medication. And these are usually not itchy. They're usually more widespread, and they can have like little tiny bumps. So they're usually that sandpapery feel. And again, if there's redness, it's dark. It's definitely harder to see on dark skin. So they may not describe any redness. Another important role that nurses play in stewardship is with antibiotic timeouts. And these are most often done during rounds with the doctor or team. Again, I've always worked in a hospital, so I had a team and, come see the patient every morning. That might not be quite the same case in outpatient settings. But some of the questions that we talk about or should be talking about, does the patient need the antibiotic or the antimicrobial? Have we done all the tests? Do we need to do any other tests? Can we change the antibiotics or stop them based on test results? Can we change them from an IV to an oral medication? IV medications tend to be more expensive. And then, of course, when you have an IV, you have that risk of extravasation or eclampsia. And, without the IV, and the patient may have more freedom to move around and need less one-to-one care. Now, of course, sometimes an IV is warranted. The patients are critically ill, if their gut's not going to be able to absorb the medication, or they just need really high doses that we can't give orally. And so that sometimes can be used to that when patients have meningitis or osteomyelitis sometimes. And then finally, how long does a patient need therapy? How many days? And can we put a stop date in on the order? Sometimes if that stop date isn't put in, the patient will just continue to take this medication until just someone notices it. And so they may end up getting more antibiotics than they need. And so a little bit more about de-escalation. So again, that refers to either changing a broad spectrum antibiotic to a narrow spectrum, decreasing the number of antibiotics. Sometimes people are taking 2 or 3. Can we decrease that number of antibiotics, or sometimes just stopping them altogether? And we're a part of this because we're the ones getting the cultures. We're the ones usually giving the antibiotics and monitoring any reactions. And again, we're monitoring for overall improvement or deterioration, and we're documenting all of these concerns. And most importantly, we communicate with the team. So we're able to help the team make decisions about testing or medication treatment. A lot of times we're the ones that get the calls from the lab, which we then have to relay to the medical team. So if we get a positive culture, then the antibiotics might be able to be tailored to treat that exact infection. Or if the patient's, the lab calls and the cultures are negative, maybe we can stop the antibiotics. So we can talk to the team about things like the patient's improvement or their ability to take PO now. So potentially decreasing or changing that antibiotic from something IV to an oral form. We're also instrumental again in shortening the length of treatment. And again, that can be by conveying test results so that antibiotics can be changed, asking those docs to put in an end date for the medication, or again, just bringing up the need for antibiotics every day. Sometimes we, we see a patient who's very sick, we put them on a bunch of medication while we try to figure out what problem they're having. And as we get those test results in, we can tailor that. So we maybe can get rid of medications again, or change them to tailor the particular infection. Now, part of the investigation into whether a patient has an infection that needs to be treated with an antimicrobial is obtaining the cultures. And this can sometimes be one of the very most important steps in the process. And it's one of the first steps. In some cases, we need to get antibiotics started right away. But it's important that we get that culture before we start antibiotics. It's imperative that we get them stat, even if they're not ordered stat. And that includes one of the things that we do. We acknowledge the order. We get that specimen. We obtain it in a way that is appropriate, and we put it in the appropriate container and get it to the lab. And so it's really important that nurses have an education about how to obtain specimens, including infection and control techniques. We need to make sure that we're adhering to any guidelines and protocols that we have. And again, discussing the necessity of the tests with the physician or the team, because we're advocating for the patient. Now, blood culture contamination is a really big problem. The CDC recommends a contamination rate of less than 1%, but often facilities have a higher rate. And the problem with the contamination is it leads to these false positive results. And that's going to lead to further testing, unnecessary antibiotic use. And then, of course, with that unnecessary antibiotic use, then we're going to have the problem with adverse effects and then increase our antimicrobial resistance. When you work with adults, it's important that you get 2 sets of cultures from 2 different sites. And pediatrics, we just get 1 set. We need to get these samples peripherally unless they're specifically ordered to be obtained via line. And if we're drawing a lot of labs, we want to try to get the blood cultures the first lab that we get. We need to make sure we get an adequate volume. We need about 10 mLs of blood per culture bottle. And if you can't, what can be ideal is if you set that culture bottle out on a flat surface and kind of put a mark on there exactly where it needs to be filled up to. So up, 10 mLs, especially if you're putting this blood directly into the culture bottle from the line. Now, most of the time, contamination occurs during the venipuncture or while transferring blood into the bottle. So to reduce the risk of contamination, it's recommended that you use a blood culture kit if you have one available. You should scrub the skin with chlorhexidine for 30 seconds and then allow it to dry for 30 seconds. Don't retouch the skin after infection or after it's been disinfected. I know we see a lot of people that will disinfect and then pull the finger of the glove off and wipe their glove, their finger with alcohol and touch again. We shouldn't do that. We often think that the culture vials are sterile because they have that little cap on top, and that's not true. When we pop that cap off, we need to use an alcohol pad, a separate one for each bottle, and we need to scrub that off. And talking about this is in our most ideal condition. There are going to be times when it's an emergency. We're not going to have a minute to scrub the skin and wait for it to dry. But in non-life or death situations, these are the practices that we should follow. One of the most common conditions that leads to unnecessary antibiotic treatment is asymptomatic bacteria. So despite what many of us learned in school, I certainly learned in school that urine is sterile, the bladder is sterile. But actually having bacteria in the bladder is common, and it's more common in certain patients. About 15% of older women have bacteria in their urine, and about half of people living in long-term care have bacteria in their urine. Virtually everyone that has a long-term indwelling catheter has bacteria in their urine. And of course, that doesn't mean that there's an infection. Once we get a urine culture, we're going to be obligated to treat any bacterial presence. So what we want to do is avoid obtaining urine cultures that aren't warranted. So except for a few special populations, including pregnant women, those undergoing a urologic procedure, and people who have received a kidney transplant in the last month, we shouldn't be obtaining any screening urine cultures. And so, again, important for us to advocate for our patients if we don't think it's necessary. There have been some algorithms that have been used to kind of guide when it is appropriate to get a culture and when we should not do that. And that's been really helpful in reducing the number of unnecessary tests. And again, other interventions are going to be education, electronic health record interventions, and some lab decision-making tools. So for a patient to really warrant a urine culture, they need to have some symptoms of UTI, urgency, frequency, dysuria, flank pain, some sort of symptom that they have a UTI. And remember that if we treat a patient with antibiotics for asymptomatic bacteriuria, we are not improving any clinical outcomes, but we are putting that patient at risk. Now, remember, I mentioned the diagnosis needs to have some symptoms, the presence of white blood cells in the urine and a positive urine culture. I also want to point out the presence of white blood cells alone is not adequate to diagnose an infection. So there's many things that can cause white blood cells in the urine that can include just having an indwelling catheter, the use of steroids or NSAIDs, some antibiotics, stones, and any radiation to the pelvis. Now, nurses will often report that they believe a patient has an infection due to the smell or the appearance of the urine. Most of us have probably done this, but we've actually done tests and we're actually wrong a lot of the time. So we should also not be testing based on the urine smell or color. Elderly patients who have falls or a sudden onset of confusion also should not get a urine culture unless there are signs of infection. And remember, no signs, don't get a culture. Now, a lot of adults will obtain their own urine for a culture. So if they are going to get the urine themselves, you just need to make sure that they really understand how to clean themselves when they get that sample. And if we have a patient who has an indwelling catheter, we want to get the urine sample from the sampling port, not from the collection bag. And we need to make sure we clean the port thoroughly so we don't accidentally introduce pathogens into the tubing and then cause an infection. But we also don't want to pull up any surface bacteria and end up with a false positive test result. And also, I'll mention that if a patient has an indwelling catheter and it's been in place for more than 3 days, that biofilm has likely started to form. And I know that we, again, talked about biofilms earlier today, which, can lead to some problems. So we want to make sure you review the policy at your facility. It's often recommended that if a patient has had a catheter in place for 3 days or more, that you remove that catheter, place a new catheter, and obtain the urine culture from the new catheter. Now, this is an example of a testing algorithm that was been used in Ontario. And I know it's really tough to see, but you can kind of get the idea. It starts at the top, I think that that patient has a urinary tract infection, and then it kind of asks questions. It can say, absolutely, you need to either obtain a culture or discuss this with the team, or it could give you some recommendations for things to do instead while still monitoring the patient for symptoms of a urinary tract infection. And then I also want to mention the bacteria in the urine without symptoms of infection is just colonization, which again, we talked about. So again, that's that bacteria or other type of pathogen that's present, but it's not causing any problems. If you have an infection with that, you're going to have some symptoms, and you potentially have some harm. So many of us are colonized with something, especially because we work in healthcare and we're exposed to lots of germs. And again, this is repeating some of the things from earlier today. When we're colonized, we have that ability to spread that pathogen or those germs throughout the environment and to other people, even though we aren't showing any signs of illness. So again, some facilities, they may screen for some types of colonization. Again, doesn't mean you need any treatment, but it's always helpful to know if your patients are colonized with something and make sure that if that patient is transferred somewhere else, that receiving facility is aware that they have a colonization. C. diff testing is again something that we tend to over-test, and this patient should only be tested if they meet criteria. So the patient needs to have had clinically significant diarrhea, at least 3 in a 24-hour period, with 5 to 7 on the Bristol stool scale. We also want to rule out other causes of diarrhea. So lots of things can cause diarrhea for a patient that's hospitalized, and that includes using laxatives or stool softeners, and being on internal feeds, chemotherapy, chronic bowel disease, and the use of immunosuppressants. And I know we talked about C. diff a little bit earlier as well. And again, not all of that C. diff that you may have in your body can cause this infection and these symptoms. So you need a two-step test to diagnose C. diff. One, to see do you have C. diff present, and then a second test to see if there's a toxin that's being produced. So you may have a C. diff that's positive and the toxin's negative. So you wouldn't have a C. diff infection. So remember, if you send these tests, if you're waiting for them, and if you get one result back, don't change anything until you get both results. And again, some other things about C. diff testing. We don't want to retest within 7 days. Don't test for a cure. There's no need to treat with medication and then test at the end. And again, something that nurses tend to do is believe that someone's the smell of their stool indicates C. diff. But again, the tests have shown that we're not as reliable as we think we are. So don't test just on that. And then if the diarrhea goes away, no need to retest. So if someone has kind of met those symptoms initially, but before you are able to get the chance to obtain the stool for testing, their stool has gotten thicker or has stopped, then you don't need to send it. Also, just for this accuracy, we need to make sure that when we send stool, it does need to be liquid. And we need to either have it in the lab within 2 hours for testing, or we need to have it refrigerated. So make sure that if you're not able to get it to a lab right away, it is in the fridge so that we have accurate results. And again, here are some algorithms again to help people determine whether they need to collect stool for C. diff infection testing. This one is from Stanford, and again, tough to see, but you kind of get the idea. And this one is used by Nebraska Medicine. And again, if you want to help, or if you want to develop a algorithm of your own, you can look online. And there's lots of resources, so you can either, you can make one that's tailored to the facility that you work at or the type of patients that you care for. Now, when it comes to taking part in antimicrobial diagnostic stewardship, many nurses worry that this is going to add work for them. And there's several ways that we can combat this. So first of all, bedside nurses, bedside staff need to be involved in the development and implementation of any algorithms or guidelines. Because what we want to do is not add work. We want to make sure that anything that any guidelines that we make of algorithms are going to work well with the workflow that we already have. And we already provide a lot of education to patients and families. And so we can continue to educate them about over-testing or the risks of over-treating. Another barrier can be either lack of support or that, that doesn't seem like the nurse input is valuable. And that's where leadership really needs to step in. One of the core practices of stewardship is leadership support. So your leader can help the clinician team, can help nurse leaders get together and develop a relationship where the nurses are encouraged to give input. This is, again, something I worked in a teaching hospital for a long time, so it was something that we did every day, but that's not the case everywhere. So you need to have a good relationship between nurses and clinicians so that we can have a environment where we're safe asking questions and educating one another. Some of the input that we can give to physicians or the medical team to help with decision making would be things like, we're really having a lot of trouble with vascular access for the patient. So IV medications may be difficult to administer, or the patient is not able to take medication or mouth, they can't swallow pills, something like that will help the team make decisions. And then, of course, and this happens with all new nurses, and some of us always feel this way, is that we just feel like we don't have a lot of knowledge. I I shouldn't be telling a doctor what to do. They know a lot more than me. And it's true to an extent. A physician and a pharmacist are going to know a lot more about medications than most of us. But we spend the most time with patients, and our input's super valuable. So while we're not recommending specific medications or lengths of treatment, we can advocate for the patient for that appropriate treatment. And again, some of those feelings of inadequacy can be overcome with education. You can have a unit champion who can work more closely with the stewardship team to be an advocate for us as well. And then, of course, when we have to call and talk to a doctor, we tend to get a little bit worried sometimes, but we can use this SBAR tool. And I know that most nurses are familiar with that, where we describe the situations ourselves and the patient, relay any background pertinent information. It doesn't need to be the person's whole history, but just the pertinent info, our assessment, and then our recommendations or what our ask is. Now, I have a few examples on here, but I'm going to skip them for the sake of time. But these will be included in on the website and in our ebook packet. And one of the last things that's really important, and again, goes back to communication, is making sure that we're giving this information to staff who are going to receive the patient if they transfer to another unit or another facility. We want to make sure they're aware of the patient's diagnosis, any medications, when the last day of medication is, if they're going home with or be transferred and they're going to be discharged with a medication, what's the last day they should be receiving it. If you did any screening, make sure that new facility or that new unit is aware of it. And then again, takeaway points, antimicrobial use comes with risk. With risks, increased use can cause countrywide resistance. And these programs seek to decrease unnecessary medication use, increase the appropriate course lengths, decrease the use of broad spectrum antimicrobials, unnecessary testing, and improve patient outcomes. And of course, we are so valuable and so vital to the healthcare team, and we should be involved in stewardship programs. I think that is the end of my official slides.
Thank you very much, Melissa. That was fantastic. We did have one question. We had a couple of other questions that we again will post. One question came across. So if a culture comes back 20 to 99,000 for ESBL, is this considered colonized organism? And am I right to say the antibiotic should not be ordered for this because it's not above 100,000?
That is a great question, and I don't think I have the answer right away. Again, I've taken care of patients that have a long history of colonization and different types of infections, and a lot of times their treatment was determined by previous infections. So we had kind of different standards for different patients. I can look more into it, and I can have the answer available on our website.
Great. All right. Thank you very much. If you have any other questions, please feel free to put them into the chat and the Q&A, and we will absolutely address those and put them on our website here in short order. So thank you very much for that wonderful presentation.